So this is a series of cases. They start off sort of simple and they get a little more interesting. So this is a basic case as a pulmonologist you might see. This was a 43-year-old white female with a long history of cough. And I actually picked her up. I picked her up from one of my partners who moved on. So I didn't do the initial history and physical. But anyway, a barium swallow was negative, but she did seem to have some reflux symptoms. However, ambulatory reflux testing was negative, and that's probably a pretty definitive test in that regards. A sinus CT was negative. She was treated for allergic rhinitis with no help, and she had repeated her spirometry, which was consistently normal. So what is the differential of a chronic cough? And again, this is bread and butter, outpatient medicine or outpatient pulmonary medicine. And when we look at the differential, remember this means that there's nothing on the X-ray or CT that is directing you to something more specific. But vast majority of cases will either be upper airway rhinitis or sinusitis, asthma, reflux, chronic bronchitis, which by definition is phlegm several times a week for several months out of the year, and what's called a post-infectious cough, which is usually fairly readily apparent. I kind of look at that as temporary asthma. So whenever I have a patient with a chronic cough, I continue to come back to these possibilities, and it very often is indeed one of them. So in this particular case, we start with the X-ray, and like I said, you got to make sure there's nothing on the X-ray that's going to direct you before you go to that differential. She's got a little granuloma here, but otherwise, this is a normal chest X-ray. And one thing that we'll talk about as we go through, and I'll show you, is looking at X-rays. And anytime y'all want to look at an X-ray with me, if you're at the VA or you see me, feel free to grab me. I'm glad to look at X-rays with you. I think there's more information on X-rays than maybe we're teaching y'all, because we're teaching you to go right to the CT. And maybe that's not always the right answer, and I'll show you a case today that maybe demonstrates that. This is her spirometry. And likewise, spirometry doesn't have to be complicated. There's lots of numbers here, and I'm going to show you these more up close in a minute. But first, I just want to show you the flow volume loop. And you look at the flow volume loop for two reasons. One, you're looking for evidence of airway, variable or fixed airway obstruction. And if it's on the expiratory loop and it's flattened, that'll be variable intrathoracic obstruction. If it's flattened down here, and this really isn't flattening, she just kind of didn't breathe out consistently. This one is better. If it's just flat on this side, it's variable extrathoracic. And if it's flat on both, it's a fixed obstruction. You don't know exactly where it is. But as far as looking at the numbers, I'll teach you a little differently than y'all are being taught. I'm getting the impression here y'all are taught to look at the FEV1 FVC ratio initially. I would tell you to look at the FEV1 and the FVC. And if either one is below 80% of predicted, then that's abnormal. If both of these are above 80%, the FEV1 or the FVC is above 80% of predicted, technically those are normal. And you can look at the ratio, but I'm not sure that's the starting place. Now, an FVC is a very reproducible and accurate test. You tell the patient to sit down, take in a big breath, and blow out as hard and fast as they can. And they need to blow out at least 6 seconds. The amount they blow out in the first second, the FEV1, forced expiratory volume 1, is compared to lots of patients the same age, race, sex, and size. So if you take a whole bunch of people, the same age, race, sex, and size, we compare that and we say, what are you in comparison to your predicted? And then the forced vital capacity is the total you blow out. So if you can blow out at least 80% in the first second of what most people do, and a total of at least 80%, you're normal. Now, if either one is abnormal, then you look at the ratio. And all the ratio is telling you is it restrictive disease, meaning those two values are reduced proportionally, or is it obstructive, meaning the FEV1 is reduced relative to the FVC? And I will tell you spirometry is that simple. I will tell you not to get too caught up on all the rest of these numbers. And you can sometimes get some more information from some of the other numbers, but honestly, if I could get you just to look at the FVC and FEV1 and then look at that ratio, I think you'll find it a little easier and not get confused by all these numbers. So this lady's obviously, if anything, super normal. Does that mean she doesn't have asthma? Does not mean she does not have asthma. Okay, so occupational asthma can be defined differently. And when you look up in a textbook of occupational medicine, it tends to define occupational asthma as new onset bronchospasm due to sensitization to a specific antigen at the workplace. But in all reality, this journal, I think, defines it a little better because I would consider occupational asthma any of these three. So reactive airway dysfunction syndrome caused by an acute inhalation of an irritant at work. And then pre-existing asthma worsened by workplace. That's, if you go out into the world and open an office, that's what you're going to see. You're going to see people who either knew they had asthma, or if you take a good history, they almost certainly had it, and something at work is now setting them off. Much more common. Although on the boards, this is what you're going to see. They're going to ask you about toluene, diisocyanates, and trimetallic anhydride or red western cedar. But honestly, that's not what you see when you get out. Unless you're in a particular area where there's a factory or something. Okay, so this patient, when I couldn't figure out what was wrong with her, I said, you know what, I'm going to start all over. And I sat and I just took a history from her. And what she told me was, you know, when I'm around the dust at work, they're remodeling, and she worked at the VA in Augusta. She worked at the VA nursing home in Augusta. She was a nurse, but she really did kind of administrative stuff. And she goes, well, they're doing a lot of remodeling, and it seems like the more remodeling they're doing, the more bothered I am. And when I'm away from work, I seem to do a little better. Well, that's diagnostic. And I put her on Symbicort, told her to stay on it for a while, and she got well. I didn't have to do more tests. I just had to teach her a little bit about avoidance, and she was good about it. She didn't, when it was real dusty, she would stay away from that part of the nursing home. And she was a good patient. She actually was a belly dancer, and that was her hobby. And I was at a fundraiser a number of years later, and they were the entertainment. And I belly danced with her, and she had no dyspnea. She did fine. So the point was, those were super normal PFTs, and she didn't wheeze. You didn't hear anything on exam, but the history is what gave the answer. So now they're going to get a little harder. This was a 49-year-old white female with a cough for several years. She was a non-smoker. She had some dyspnea. She had a negative methacholine challenge. And in methacholine challenge is doing spirometry, then giving sequential doses of methacholine and repeating the spirometry after each one. She had a negative upper endoscopy and a negative barium swallow. She had a negative sinus and neck CT and a negative ENT exam. And she had already seen gastroenterologists, ENT. She had seen another lung doctor. She had had therapeutic trials, like I just said about the patient I presented. She didn't get better. This is her x-ray. And this, again, is a normal x-ray. All right, this is her pulmonary function test. And if you'll notice, the FVC is normal and the FEV1 is normal. One's 115% of predicted, one's 102% of predicted. But look at that. You can't fake that. Your lungs empty in a very specific way. And when the flow flattens like that on both loops, it's very hard to fake that. You could try sticking your tongue into the tube when you do it. But remember I just told you she had a methacholine challenge study? And she had spirometry after spirometry after spirometry. And you can usually tell when somebody's doing that. This is real. This is just as good as a CT scan or a chest x-ray showing you that there's a fixed airway obstruction. Okay, do you all understand that this is diagnostic? It doesn't matter that they said they didn't see anything. So I saw that and I said, well, golly, we need to look down there. But the first thing I did was I went back and looked at the next CT. Well, when I look down there, this is what I see from above the cords, vocal cords. And you're kind of getting that impression there's something down there. And look at there. There's a web there just below the cords. And you would have predicted it was in the trachea because she'd already had an ENT exam. They didn't see anything up above the cords. It's not going to be in the distal airways because it was a fixed obstruction. And she had been intubated one time in her life. And presumably this was a result of that. This is what it looked like beyond it, completely normal. But as you might imagine, putting the bronchoscope through that, she couldn't breathe at all when you went through. So it just went through quick and came back out. When I went back and looked at the CT, it's there. The radiologist either wasn't given enough information or just, it looked so good except for white there, he didn't see it. It's right there. Now, what was confusing to me is that somebody else that could look at those flow volume loops and not said, we have to pursue this. So the point I'm trying to make to you is, even when you read a negative CT report and you see something like that, you have to pursue that. You don't say, oh, the CT's negative, I'm done. CTs aren't always correct, or they may not be read. You should go look at scans yourself, especially when you have a difficult case, because sometimes the radiologist needs a little more information, or with a little more review, we'll see something, or maybe you'll see something and help you make a decision. This lady had lasers, ENT surgery, and she's well. I was actually walking into a hospital, and this is like, again, years later, and this woman goes, Dr. Rosenblum, do you remember me? I was like, I don't know. She goes, you fixed me. So there is rewards in medicine if you're persistent. They're going to get harder now. Oh, just to finish on the variable and fixed airway obstruction, one way to think about it is, this is the expiratory loop, remember, and when you have a variable obstruction and it's intrathoracic, when you're exhaling, if you will, you're pushing it shut. And when you inhale, you're pulling it open. So you only see the flattening up here. When it's extrathoracic, if you will, you're sucking it closed and you're pulling it together. And when you exhale, you're pushing it open. So that's one way to remember which loop is flat on which side. In this case, you don't know where it is because it's a fixed obstruction. Okay, this is what she looked like after surgery. And again, it's still a little flattened on both sides. This, that's just her coughing or something. But it's much improved. Her numbers are a little better. And she felt much better. So now everybody can read PFTs, right? They're simple. All right, this is a harder case. Now, whoever makes the first diagnosis on this case wins a prize. 66-year-old white male with no past medical history. He awoke with right jaw pain, along with some chest and back discomfort. He passed out going to the bathroom. He wanted to go see what was in his mouth. He was hypotensive in the ER despite fluids. He had a mild anemia and 2 negative troponins. This is his EKG, and it doesn't show anything. It's sinus rhythm. It's on the slower side, but it doesn't show an infarct or ischemia. This is his chest X-ray. Is this a normal chest X-ray? So what strikes you? He's got a wide mediastinum. Now, I will tell you, with that history and with this X-ray, that's diagnostic. I will tell you that as a pulmonologist. And indeed, this was actually Christmas morning. And the hospital I was at before I came here was a small hospital. We didn't have heart surgery. And he, told me his history and all, and I was already a little worried. And I said, well, let's get the plain film. And they brought it up. This is before we had everything digitalized. They put it up on the screen, and I picked up the phone and called the cardiothoracic surgeon, and got him transferred down to University Hospital where he could be saved. And they did a diagnostic study. They did a CT angio. And that's considered the test of choice now, not a true angiogram. And they don't see it. This is all the way down to the heart. They don't see it. Now, there is a finding here. Does anybody see something that bothers them? Well, this is just a cut where you don't see it, so no. Well, I'm not sure exactly what that is, but that is thickened pericardium with something in it. So I don't think that's not air, but there is a difference there. So I think your point's well made. Okay, let me ask you a question. If he had a wide mediastinum like that, and they don't see anything here, there's still a wide mediastinum, isn't there? I mean, it's there. He's anemic. He's hypotensive despite fluids. Well, anyway, they went down further on the CT, and they see this. That's the gallbladder. And they go, oh, it must be cholecystitis. And actually, I was leaving town that day, and I said, I guess that's what it is. That motive must be. The cardiologist actually did a cath, but didn't shoot the aorta. He did the vessels to make sure he wasn't having a right-sided heart attack or a heart attack. So the patient on this, based on the scan, had a cholecystectomy. And I left town. And as it turns out, later in the hospitalization, because I think they repeated the echo, he had a pericardiocentesis. What do you think it showed? Nope. Showed blood. And what do you think his right-sided heart pressures were? Right here, right here, right here. I give him fluids, he doesn't respond. He's got pericardial thickening or something around his heart. He's anemic. What does he have? No. He's got a wide mediastinum. And what does he have? He has a dissection. Because they just didn't see it on the CT. The blood dissected into his pericardium. He had a little bit of tamponade. He's anemic because the blood is in his... Why is his gallbladder distended? That's exactly right. And keep that in mind. I've seen at least one other case that was misdiagnosed as acute cholecystitis and it was actually an acute ventricular septal defect. So I told you that I left town. And I got called about 2 weeks later, after I was back in town, middle of the night. They go, the guy's back. He's got the same kind of symptoms he had before, pain, and he's short of breath. And but it was mostly the pain. He actually got flown in by helicopter he was from outside of Augusta. And I didn't know at that time that he'd had a pericardiocentesis. And I'm in bed, it's the middle of the night. And I go, well, it must be referred pain. I mean, we cured him. We took out his gallbladder, right? And he got sent home again. Well, he came back in florid pulmonary edema finally. And he had wide open AI. And they finally figured out that he really had a dissection the whole time. He was already in renal failure a little bit at that point. He's lucky he survived. But the point is, the CT being negative doesn't mean you don't still ask yourself what's going on. And I should have pursued it further. I think I would have put it together when he had the pericardiocentesis. But nonetheless, the guy actually did eventually get an aortic valve and his aneurysm repaired, and this is his x-ray. His renal failure went away. So he did okay. That's his valve, his aortic valve. Remember, the aortic valve is kind of lower down than you think sometimes. But when he first came in, his symptoms and the x-ray were consistent with the correct diagnosis. And we just weren't pushing hard enough to be clear that that's not what we had overlooked. And he's very lucky. Now, when somebody comes in with acute chest pain and they're hypotensive, what are the things you want to absolutely not miss? One of them is this. What else? An MI. And what else? One of y'all mentioned it. Somebody said cut off of the pulmonary artery. Pulmonary embolism. So those are the things you really don't want to miss when somebody comes in. All right, you ready for another one? Yeah.
Do you think so hypotensive that there should be
Well, remember, this guy was well until this happened. So it's not like there was time for it to dilate. He just needed enough blood in there to compress. Now, if it happened over time, yeah, you're going to see more fluid before you might develop tamponade. But when it happens just like that, meaning the blood, when he dissected, it dissected down into his pericardium. I mean, his pericardium is not terribly distensible, so it's going to fill up with less blood. All right, next case. There's a 52-year-old white male with new onset seizures. Long smoking history. His father died with a brain tumor, although he didn't know any more about it. No known exposure to tuberculosis. No history of tumors or malignancy. He had no significant travel and no occupational exposures. On exam, he was lethargic. He indeed had left-sided weakness. He was afebrile. His lungs were clear. Chest X-ray showed a poorly defined nodular infiltrate in the lingula, but the CT of the head revealed a ring-enhancing lesion in the right parietal lobe. Had a little bit of a white count. Sodium was a little low. This is the MRI, not the CT. It's pretty ugly, yes? And this is the X-ray where you can see it marked. There's just a little non-specific infiltrate here. So, what do you think he has? And that's exactly what the referring hospital said. I was down in Thomasville, Georgia, and we had a Gamma knife down there, believe it or not. This guy went to Albany. He actually had no insurance. They couldn't send him to us for Gamma knife therapy fast enough. They had bronchoscoped him, but did not do transbronchial lung biopsies. And the diagnosis was, of course, metastatic cancer. The lesion's too big to do Gamma knife therapy on anyway, but they were very aggressive about wanting to get him out. Well, when I saw him, I was like, I'm not sure we have a diagnosis. And I suggested rebronching him. And I did transbronchial lung biopsies. And I didn't get a specific diagnosis. So I told the neurosurgeon, I go, I still don't know what he has. And one thing you'll see when you rotate with me is I will tell you when somebody comes in, you need to make a diagnosis. You can't start just treating numbers. You know, of course you stabilize people, but you need to know what you're dealing with. And I will be very persistent on that when you rotate with me. I think Bilal knows that already. Make a diagnosis, identify the problem, treat the problem. Because otherwise you're floundering. So I said to the neurosurgeon, I go, we need to know what this is. And before we see what it is, and I made up the term pulmonary cerebral syndromes. That's not something you'll find. But it made sense to me. So malignant disease, and indeed the most common cause of metastases to the brain is lung cancer. So as a lung specialist, I need to have some understanding of that. Lymphoma can present in both places. Other cancers can metastasize to the lungs and the head. Inflammatory vasculitis, which is the classic one, gives you lung and head. We don't call it that anymore. Wegener's. What is the new name for Wegener's? Yeah. It's Wegener's, okay. But on the test, put the other one. Infection, bacterial, fungal, and mycobacterial. Actually, the most common cause of a lesion in the head in India is a tuberculoma, believe it or not. Okay, so what they do is they do a stereotactic biopsy. They put the guy's head, in bolts to make it still. They put just enough of a hole in the skull to get through, and they get the needle and stereotactically make a diagnosis. What is this? It's a diagnostic slide. Those are all white cells around a... It's not a granuloma. Granuloma... No. That's a sulfur granule. So if you got up real close to that, you'd see all the branching filamentous bacteria. That's a sulfur granule. And indeed, this guy had actinomycosis. And when you see patients with a brain abscess, diagnostic delay limits therapy. And it tends to be a contiguous support to focus. Hematogenous spread is not uncommon, and often the lungs being the source. Again, as a pulmonologist, I need to have some understanding of that. After trauma, which may be the same as contiguous. And continuous means like sinus and otitis. We don't see that a lot in this country because we throw around the antibiotics so liberally. And finally, cryptogenic. This guy presumably had hematogenous spread from the focus of his lungs. And he got better with therapy for actino. Remember, actino is associated with poor dentition. It can be associated with being an alcoholic, both of which he had. And so, we have actino. It's an anaerobe, strict anaerobe. And it's in our mouths. So we all probably aspirate it periodically, but we clear it. If you get a big enough bolus or you have bad dentition and you have more in your mouth and stuff like that, that's what he had. What is the differential we always talk about? Actino. What else is a gram-positive filamentous organism that can be confused with actino? Nocardia. And nocardia can be differentiated from actino by stains. Actino is not partial acid fast positive, whereas actino is PAS positive. So you can differentiate it on stains, and that is something you potentially could be asked. The other thing is nocardia tends to occur in immunocompromised patients. It often gives you more than one lesion. This is a very typical presentation of actino with one big lesion and a pulmonary source. He did well. We didn't do gamma knife therapy. Okay. This is a patient that was a 75-year-old who presented to the emergency room with acute onset of chest pain associated with shortness of breath. So remember what we think about when we see acute onset of chest pain, although that doesn't mean it's going to be the diagnosis. History of COPD with a baseline FEV1 of 1.3, which is low. History of ischemic heart disease. Physical exam revealed a surprisingly comfortable man. His blood pressure was a little high. His pulse was a little high. He had diminished breath sounds with some hyperinflation. Heart exam was unimpressive. The ABG revealed hypoxia without CO2 retention. And I asked, what's your differential and what further studies are indicated? What do you want to start with? What are we going to start with? How about a chest X-ray? That was good. Thank you. You know what a fungo is? Well, a fungo is the ball that the batting machine throws you, so that they're easy to hit. So thank you for throwing me that. Okay. Okay, so this is a chest X-ray. It's not a great film, but I will tell you can make a diagnosis from this film. Y'all need to rotate with me and read more films. It's very hyperinflated, but noticeably which side is more hyperinflated? Remember the right lung, even though it's bigger than the left lung, the right hemidiaphragm is usually not as low as the left because of the liver. Okay, remember your right lung has 10 segments and your left lung has 8 segments. So your right lung is 55% of your function, your left lung is 45% of your function. But even though that's the case, the right hemidiaphragm is usually a little higher than left because of the liver. So even though you don't see a pneumothorax because he's so hyperinflated and the film's overshot, he has a pneumothorax on the right. And you should be looking for that when you see this film. And indeed, well, this is before digital films, but on a digital film you would just make it darker or lighter. We used what was called a hot light to look at it. That's what he had. So he was just a COPDer with a pneumothorax. And he was comfortable because unless you're on positive pressure, you really don't get true tension pneumothoraces. Tension pneumothorax means that you're decreasing blood flow back to the heart because of the increased pressure. Now, you can get a tension pneumothorax with a ball valve type lesion, but those aren't common. Now, bad COPDers can look like they're going to crump with a pneumothorax because they don't have any reserve. But if you take a healthy person and give them a pneumothorax, unless they truly have that ball valve lesion, they're not going to get a tension unless you put them on a ventilator. So where that comes into play is sometimes patients get a pneumothorax from, let's say, trying to stick a subclavian line or another procedure, and then they get sicker and have to be intubated, and then they crump. So whenever you see somebody, you intubate them, and all of a sudden they just really get very hypotensive, maybe even bradycardic, make sure you understand whether or not somebody had been sticking their chest. And that has indeed happened to me, and you keep that in mind. All right, I got one more case for you. How am I doing on time? So 2 o'clock's about what y'all want? Yeah. Because I can stretch it out. All right, this is a case I saw not too long ago. This was a 55-year-old white male who was in good health. And these first 2 lines are exactly how his H&P read. It said 1 day history of upper abdominal pain, nausea and vomiting, and an elevated white count. So that was put into the subjective part. The very next line in the H&P was, quote, CT scan very positive for acute cholecystitis. So already you're sort of seeing that there's not really much thought being put into this subjective part of history and physical because he's already decided that the CT is diagnostic. Okay. Past medical history, he had COPD and bipolar disease. Social, he smokes, but he doesn't drink. Labs, he only had a slightly elevated alk phos and a normal bilirubin. He was sick. He had a lactic acid of 3.5 and normal pancreatic enzymes. Okay, this is the CT. Sort of looks similar to the last one with that sick-looking gallbladder. Now, I'm going to take an aside right now and tell you that this is a copy of Cope's Early Diagnosis of the Acute Abdomen, which I pulled out and reread. Right before I gave this lecture. This was originally written in 1921, I believe. This is 22nd edition. I think there's even a newer one out. I would tell all of y'all to read this for several reasons. It'll make you a better clinician. 2, has anybody read it? 2, it's easy to read. It's a fun book to read. He writes very nicely. It's been updated by a surgeon who's still alive. And the introduction that the newer surgeon has is emphasizing some of the points I'm trying to get y'all. But I think you'll enjoy it. You can read it in 2 days. It's very easy to read. I read it when I was a senior med student, I believe. But I think you'll enjoy it. But anyway, going back to our case. So his gallbladder looks sick. There's actually a diagnostic feature on this scan, which I'm not sure I expect you to see. But first of all, does his history really sound like cholecystitis? I mean, he's had a sudden onset. He was well, just like that. And 2, his labs really don't support the diagnosis. His alk phos is a little high, but that was all. So they take the man to the operating room, and they open him up, and he looks like he has an inflamed gallbladder. But the assisting surgeon actually commented, there just seems to be more inflammation than I would have expected. Afterwards, they bring him to my ICU, intubated, and I'm now responsible for this man. And he's just not getting better over the ensuing 2 days, or several days. And so I did exactly what I want to teach y'all to do. I started back at the beginning. I went down to look at the original CT with the radiologist. And he looked at this and he said, he saw it right away. And I knew we had a problem. This is the lung windows, but you can see it a little better. What does he really have? Exactly. Who said that? He has a posterior ulcer that perforated. It happened to perforate onto the gallbladder, basically. And they took him back. They found it. And he did get well. But there was certainly enough there to make you think that maybe something's not right. And, you know, the gallbladder can necrose, but it doesn't pop, if you will. It doesn't have air in it. It doesn't give you free air. Obviously, your stomach does have air in it, and there's the free air right there. And the radiologist saw it as soon as he pulled up the film. It was a different radiologist. But he saw it. I mean, he just pulled it up and goes, look, there's free air. And they can be that subtle. And I'll remind you to look anteriorly in front of the liver when you look at CT scans for that just like that. And I'll go back. I mean, it'll be a little more subtle, but you look for it and, you'll learn how to find that. So this guy had a diagnosable disease, and when the things didn't seem right, even at the time of the operation, there wasn't enough initiative to say, well, let me just go back and look at that CT again. Let's think about it a little. Let's explore them further. I think they did it laparoscopically initially, and of course you don't see as well. And he did well, but I do believe there's a suit involved in this case because he was sick for a long time, but he survived. That's the last case I have. I'm welcome to entertain questions, but I hope I've stimulated you to be aggressive about pursuing a diagnosis, and when somebody's not getting well, to ask yourself what you might have missed, and even more importantly, to sometimes start at the beginning. And I will tell you one more case that emphasizes that point. This is likewise a patient I saw right before I came up here. And this lady comes to the emergency room complaining of abdominal symptoms. And she'd been laying around in bed because she just didn't feel well. And on X-ray and CT scan, she had either an ileus or an obstruction. But she probably had a small bowel obstruction. But she also had a finding on her workup of a pulmonary embolism. Well, the hematology gets called, and because she must be hypercoagulable because she has a bowel obstruction and a PE, so she must have colon cancer. The surgeon comes by and sees her and says, well, I think it's probably an ileus, but if it's not, she's got colon cancer and, she's hypercoagulable. And, there really wasn't anything on the CT other than the obstruction, and I felt like she needed to be explored to see what was really there. And when you went back and talked to the lady, she was very clear, the course. She said, I started having abdominal symptoms, I took to bed, and I really never had respiratory symptoms. And her daughter gave that history because she was already pretty sick. So what came first? What's Virchow's triad? Stasis, inflammation, hypercoagulable. She wasn't hypercoagulable, she just had been bedridden. And we finally got her to explore, and she just had a benign bowel obstruction. She just had nothing dramatic. She didn't do well because she laid there for several days before she had an operation. So one has to be vigilant about not making assumptions, being certain that you're pursuing the right diagnosis. And again, anytime you want to look at x-rays, please feel free to ask me, and I'll be glad to look at them with you.